Welcome, everybody. I'm Dr. Ken Kaufman. Hopefully y'all can see me. Let me know if you cannot see me in the webinar, but I want to welcome you. And take a moment and pump into the chat there. If you can see the chat, there's a little toolbar down below. You can get in. Let me know where you're at. Let me know where you're from. I'd like to know. And we'll go ahead and let some more people get into the Zoom room here. And while we're waiting for that, just wanted to welcome you inside the training room. This is our podcast room in our studio where we hold a podcast called Inside the Training Room. And it's our way of being able to get in and speak to former and current professional athletes, medical professionals that are at the top of their field in surgery, orthopedics, athletic training. Got some folks from Denver, got some folks from Georgia. I spent a little time up in Georgia myself. Went to chiropractic college up there. Trying to get the lighting right here, guys. So hold on one sec. So, all right. So yeah, go ahead, and as you're coming in, let me know where you're from if you can get into the chat feature. And while we're waiting, I'll also pop in a poll here and go ahead, and that should come through. Go ahead and check it out and see if you suffer from any of these common injuries. And I know in the invitation, we were going to go ahead and talk about just 5 of the top running injuries. But as I was going through and putting together the presentation, I discovered there was a couple more that I really needed to address. So, so far, shin splints is starting to come in as the most common, but we got some Piriformis Syndrome, Achilles Tendinitis. So there we go. There is some runner's knee and some IT band syndrome. And these, just a little bit about my background. I used to be a runner. I wouldn't classify myself as a runner per se. I did get out and I attempted to run. It was not the prettiest thing, but I did run. I ran half marathons, and I've run a couple of marathons, and eventually moved into triathlon, which I've done up to a half Ironman distance in Florida here. And here we got some folks coming in from Ridgefield, Connecticut. Welcome, John. Oh, this is interesting. And there's another poll question coming up, but someone's a coach to teenage girls, and those are the things he always sees, and he especially sees shin splints. And I would agree, John, that I see shin splints quite a bit in my practice in young girls, and I'm not sure exactly why that is, but that's part of it. And I don't know if we'll find that out ever, but hopefully during this we can kind of come up with some ways that we can address some of these issues. So I'm going to go ahead and share my screen. So welcome to the Runner's Injury Prevention, and we're going to talk about not just the injuries, but also some prevention strategies, because, let's face it, if we can prevent some of these injuries, then that's going to save a lot of people some time. I have a rule where we want to make sure that somebody has consistent gains and consistent progress in their training program. And the number one rule to make sure that you have consistent gains is to don't get injured. And if you can avoid injury, you can make some great strides in your progression in whatever sport it is. If it's baseball, if it's weightlifting, if it's triathlon, if it's running, if it's tennis, if it's badminton, I don't care. It doesn't matter. If you can avoid injury, you can have consistent gains. And what I think you'll discover in part of my philosophy when working with athletes is that most often athletes are so driven that they keep, trying to perform, and eventually they wear themselves out into an overuse injury, and they end up being sidelined with that injury. And being able to avoid injury is just as much as trying to manage the stress loads that are that are happening during a training program or competition. So regular rest is one of those important things. But for those of you that weren't on the beginning of the podcast or the first couple of minutes, a little bit about myself. My name is Dr. Ken Kaufman. I've been in active practice, chiropractic practice for the past 27 plus years, right down here in Sarasota, Florida. My practice is Sarasota Sports Medicine, and I treat athletes from all kinds of disciplines, all kinds of sports, from the NBA to Major League Baseball. I happen to be the team chiropractor for the Baltimore Orioles. Their spring training facility is right down here in Sarasota, and so I'm contracted with them to go in and treat their athletes during spring training, and then if there's any players that are on the extended DL and down in Sarasota, I'll go in and oftentimes take care of them. As I said before, I was a runner and a triathlete, but I would consider that in a previous life. And in fact, it was a severe back injury that sidelined me I couldn't run anymore. I mean, I can, but it's too much trouble to get out and run. So, but I keep fit by, biking and doing non-impact type of sports. So, so let's go ahead and let's jump right into it, because I'm sure I want to make sure everyone's time is observed and we're not dragging things out. But what you're going to discover today are the top 7 running injuries. And you already saw those. I put that on the poll. We're going to talk about those injuries themselves, but then towards the last part of the webinar, we're going to talk about some prevention strategies. Again, if we can avoid injury in the first place, we're much better off and a lot farther ahead in the long run. And then we're going to talk about some simple methods of self-care to be able to avoid those injuries, or if we are experiencing an injury or some chronic overuse, some methods of self-care. And then we're going to talk about some of the best conservative treatments that I've seen that range anywhere from, simple massage or myofascial release or foam rolling up to dry needling, prolotherapy, and laser therapy. So we're going to talk about those as we go along. So let's talk about runner's knee. Now, runner's knee is commonly found and is commonly symptomatic by climbing or descending stairs, doing any kind of squatting movements, of course, running and walking. But basically, runner's knee is where you have inflammation of the patellar area, this is the patella right here. And then you have these different muscles. You have the quadriceps muscle here, the vastus medialis. You have the vastus lateralis, and then you have the this big patellar tendon from the quadriceps group. And then along here, you have the IT band attaches right in here. So oftentimes when you have a runner's knee, you get pain either below here, as in some patellar tendonitis, or you get it up here, more up in the above the patella itself. But regardless of where the pain is, it can very often become debilitating, where it'll affect your ability to run or even walk. Certainly, even rising from a seated position, you can feel it, especially if you've been sitting for a long time. You go to stand up, all of a sudden you got this pain, and it usually comes on as sharp pain. And incidentally, just to be aware that towards the end, there's going to be an opportunity to ask questions. So don't think I'm going to jump off here and not answer any questions for you. So the next thing is IT band syndrome. IT band syndrome it's a big fibrous band that runs along from the iliac crest here. If you can see that, I should redo this video. Right along in there, and it runs all the way down. And as we saw, it attaches right in the top of the tibia, right down in here. A lot of times you'll have point tenderness along the IT band. If somebody has IT band syndrome, they know it. It's very tender. If you try to foam roll that, it's extremely debilitating. But here's the little animation that shows some of these. There's some of the quad muscles, and then this is the IT band that runs right down through there. Let me run that again. There you go, IT band. So it attaches right in there. Okay, next we have ACL injuries. ACL injuries, these are not usually, these usually don't occur in younger people unless there's a severe trauma. Somebody gets hit in the knee, hit in the leg. You see this in contact sports like football, rugby, sometimes, a lot of times in basketball because of the jumping, volleyball, you'll see this. But ACL injuries, you know, it helps to, the ACL is the anterior cruciate ligament, and along with the posterior cruciate ligament, it helps to prevent backwards and forwards movement of the tibia underneath the femur head, okay? You can have partial tears and you can have complete tears. In this little animation, we'll show you, there's the ACL right there, the anterior cruciate ligament. And then here's some representation of what a partial tear could look like, and then what a complete tear will look like. So there's some ways that can be treated, especially if it's a partial tear, that can be done a little more conservatively. Just because somebody has an ACL tear doesn't necessarily mean they have to have surgery unless it's a complete tear and it's highly unstable. And then oftentimes, this is the PCL back here, the PCL, that can be torn, and a lot of times even in elite athletes, they won't even surgically repair that because the outcomes aren't very good, and that they can do some rehab to help strengthen up the stability of the knee. Okay, next are hamstring injuries. You got basically three major muscles of the hamstrings. You got the semimembranosus, you have the semitendinosus, and then you have the biceps femoris. Okay. So here you have the, this is the biceps semitendinosus, rather, this is the biceps femoris. That's the semitendinosus here, semimembranosus, and then the biceps femoris. Now, oftentimes those structures become injured in running activities because of overuse. Not necessarily overuse, but overloading. And we'll get into this in a little bit in the prevention strategies and some of the conservative treatments that can be done. But what happens, oftentimes people become quad dominant. And I don't want to get too deep into this, but many times if you see people climbing stairs or squatting, and this also occurs a lot in girls and younger boys, is when they squat with their quads and their knees drift way forward. Sometimes if they don't have good hip stability, their knees will buckle in when they go and squat. Oftentimes when we see that, that means that this posterior chain, including the glutes here, and then the hamstrings aren't really firing correctly. And if the glutes aren't firing at all, what'll happen is, especially in a running or walking locomotion movement, it'll overload these hamstrings, and eventually those hamstrings will become so fatigued and tired, then they'll fail, i.e. they will tear, or you'll get a hamstring pull. That's preventable. It's very, very preventable, and we'll talk about that. Okay, next, the number one on our poll is shin splints, also known as compartment syndrome. And this is where the tibialis anterior muscle, which, let me kick this in, the tibialis anterior muscle is, and all muscles are surrounded by fascia. That's the tibialis anterior right there. That's the anterior tib on the other side, which you'll see, it'll highlight. But all the muscles are surrounded by fascia, and it seems like the tibialis anterior has a real heavy-duty fascial covering over it. And that fascial covering actually attaches into the tibia here, and it's real tight. So as a result of the running activity and the constant dorsiflexion of the foot, which means that it raises the toe up. That's what the tibialis anterior is. It brings the foot and the toe back towards the face, which when you're running, you have to do that. Otherwise, you'll drag your toes and fall on your face. So because of that tight fascial covering, when that muscle is highly engaged, it fills up with blood. Just like, if you do bicep curls, you feel like the bicep gets bigger. When the tibialis anterior does that, you get all this pressure in that anterior compartment, and that's what causes that painful shin splints. I think this is also in conjunction with a fast growth spurt. So a lot of times this soft tissue fascia doesn't grow at the same rate. You see some children where, from 1 month to the next, they're already 2 inches taller, and you're like, oh my gosh. And that's usually that, the growth plates are in hyper overdrive in the long bones like the tibia, and this muscle and the soft tissue and the fascia just don't keep up with that growth rate. And that's painful. I had that myself. Piriformis syndrome. This can actually be something that's confused with sciatic radiculopathy or sciatica, and I'll explain why in a second. But if we look at this, piriformis syndrome usually will have pain deep in the hip. Oftentimes, one of the telltale signs is external foot rotation. If that foot is rotated outward compared to the other one, a lot of times this piriformis muscle right here is shortened, which will take and rotate the femur outward, and that will cause that foot to flare out. And then again, it can be confused, or it'll feel sometimes like sciatic pain. Let me put this in motion and explain why that is. So you see here, there's a gluteus minimus muscle. Then you have the piriformis. Those are the deeper pelvic muscles in the posterior part of the hip. And then you have the gluteus minimus, and then you have the, or gluteus medius rather, and then you have the gluteus maximus. But what happens with piriformis syndrome, let me stop this. What happens with piriformis syndrome is that this muscle, this piriformis muscle, oftentimes sits right by the sciatic nerve. And some of the fibers of the sciatic nerve will travel through the muscle itself in some people. If that muscle is hypertonic and spasmed and tight, what'll happen is it'll pinch off on the sciatic nerve, and as a result, it will cause sciatic type pain. So you'll have pain that radiates down into the leg, maybe numbness, maybe tight muscles, or burning or itching feelings down the leg or into the foot. And oftentimes this can that can be corrected by just simply releasing this and doing some stretching, doing some foam rolling. So just because you have those leg symptoms doesn't necessarily mean that you have some sort of disc problem in the spine. It's an important distinction, I think. Okay, the next one is Achilles tendonitis. Okay, this happens a lot in runners. I know when I transitioned, I used to be a heel striker when I ran, and then I gradually got trained to be able to run more on the balls of my feet. And when you do that, that transition of how you strike the pavement activates those gastrocs and soleus muscles dramatically. So of course you can have calf pain, you can have cramping, you have tight issues down in these tendons here. And oftentimes the Achilles tendonitis and Achilles problems come from abnormal foot mechanics. And in fact, even the knee injuries can come from abnormal foot mechanics. And I'll talk a little bit about that in just a second. But you can kind of see here, there's the soleus muscle, which lies just underneath the gastroc muscle. And then the gastrocnemius itself, which is the teardrop muscle that you see back there. And then you have this big long tendon that attaches right into the heel bone, or the calcaneus. This is your Achilles tendon right here. And these can tear, these can cause all, you see this in basketball players. If they land too many times, you'll get this Achilles tendon will completely rupture. And also with Achilles tendonitis, what's often, what often accompanies Achilles tendonitis is plantar fasciitis, which is, I didn't add the condition in as a separate condition because oftentimes this is seen together. But plantar fasciitis can also be very painful, and that's also due to abnormal foot mechanics. So I'm going to go ahead and exit this for just a second, and I'm going to come back to stop sharing screen for a moment. And I'm going to go ahead and open the floor up for maybe any questions that anybody has. If you have a question, if I covered something too fast, if there was something that you missed that you thought was important that I didn't address fully. I know this is a lot of information in a short period of time. Keep in mind that this is being recorded, so I'll be able to give you a recording of this following the webinar after Zoom gets it all recorded. So I'll wait for just a second. I'm going to take a sip of water. If you have any questions, go ahead and type those in. And if you're wondering where that is, if you go down in the lower part of the screen where you see, you know, your video mute polling, you can look for Q&A, or you can just put it in the chat. That's fine too. Either way. So I'm going to go ahead. We don't have any questions yet, so I'm going to go ahead and go back to the presentation. And again, if you have any questions, we'll go ahead and address those towards the end as well. Let me get myself out of the way. There we go. All right. Okay, we already went through that. Okay, so we're going to now talk about prevention. And prevention is going to have to do with strengthening, but just not getting into the gym and doing a bunch of random exercises. I'm talking about strategic strengthening, where you're going to work on balance, stability through exercise. So remember I mentioned something about the posterior chain, or the quad dominant athlete. In the idea of balance and stability, we want to make sure we create balance from the quads and the posterior chain exercises. So it's easy for, if somebody wants to do leg exercises, they get in, and especially if they go to the gym, they can do leg extensions, maybe they can do some squats and things like that, but they'll oftentimes neglect doing hamstring curls or deadlifts or different exercises that are going to strengthen that butt and strengthen the hamstrings. That's an important distinction to make, and that's true with any joint in the body. You want to create stability and balance. There's also dynamic warm-up, making sure that you're not just doing static stretching. Static stretching, in study after study, has been shown to not prevent injuries. So static stretching is not a strategy you want to follow. You want to follow a dynamic movement warm-up. An excellent resource for that is, I will put that on the website, or I'll send it to you afterwards. I'm trying to think. Leopard, Supple Leopard. That is an excellent resource for dynamic movement. Some of it's a little far out there, but it's an excellent concept of making sure that you're moving your body and your joints through full range of motion, activating all the muscle tissues of the body, and you're not just, you know, yanking and stretching on the tissues. That could be a topic for a whole other webinar, why we do dynamic movement versus static stretching, but we don't have time to do all that. And again, in the vast majority, 99.9% of the cases where I see somebody that has any one of these injuries, they have a weak posterior chain. So things like hip bridges, you'll see some of these hip bridges, RDLs, different types of deadlifts, actually looking and working on strategic and proper squat mechanics are all critical components. So here's an example of a single leg RDL. Another thing with balance, which I talked about here, is I'm a big proponent of doing a lot of single leg exercises. When you do a single leg exercises on a regular basis, it challenges the balance and stability from one side of the body to the next. And not only are you working the muscles out and working the tissues out, you're also, because you're doing things on one leg, you're also challenging the neurologic system, because there is a difference between the traditional balance. Somebody says, oh, I don't have very good balance, you know, like riding on a bike or something like that. And then stability. Stability is more local to a joint, where balance is more the brain, where the brain is helping to coordinate movements through a kinetic chain to make sure that all the muscles are firing in sequence and in order to be able to create good, solid balance. Now, most of you could probably do this if you're in a position where you can stand up, and you can do this later, you don't have to do it now. But if you stand up and then just, you know, try to balance on one leg and make sure you bring that other leg all the way up to a 90-degree angle to your abdomen and 90-degree angle down, and just balance on one side, and then go for a few seconds and then go to the other side and see if there's a difference from one side to the next. And a lot of people, their balance and stability on one side is a little bit better than the balance and stability on the other side. So anytime somebody's going through an exercise routine or protocol to help prevent injuries, you want to address that balance issue. The other problem is that a lot of people innately know that they're, not stable on one side versus the other. And so as a result, they favor the stable side because they don't want to look foolish, getting ready to fall over every time they get on the unstable side. And that's the wrong thing to do. We need to challenge that poor stability on the other side to make sure that it gets up to par. So some other prevention strategies are self-care. Now this, ice or no ice, this has been a topic of past webinars that I've done, and we're going to load those past webinars on our website archive. But utilizing ice in the RICE protocol, and we know this as everyone's heard of the RICE protocol: rest, ice, compression, and elevation. And that was a term, RICE was an acronym coined by Dr. Gabe Merkin. He wrote the sports medicine book, and he came up with the RICE, the way to name it. And as recently as 2014, he recanted that and said that apparently ice and complete rest actually delays healing. Ice delays healing by restricting blood flow and preventing the inflammatory response that is necessary to stimulate the healing of the tissues. Okay, so the way we deal with the swelling that happens, which inflammation and swelling are two different things. The swelling is the bad part that we have to manage. And we do that by movement, and we do that by muscle contraction. The swelling is mediated through the lymphatic system, which is a passive system, and it requires muscle contraction to move the fluid along the system. And so now in some cases, if you have, let's say you have an ankle sprain, it's not completely torn, but you have an ankle sprain. You need to be up and walking on that nice and easy, providing some nice, easy muscle contraction on a regular basis. I know this, I'm walking the talk because I severely tore my ankle up. I had 80% tears of 2 ligaments in my ankle. I was doing kickboxing, rolled my ankle, and I was up walking around the next day. And that helps to facilitate getting that fluid out of there. And there's a device on the market, a couple different devices. I like the Mark Pro, but it doesn't matter. It's an electronic muscle stimulator that helps to, and this is after I tore my ankle up, it helps to contract the muscles automatically without having to consciously do it. And you can see how it's contracting the gastroc, it's contracting my quads, and it's actually causing that pumping action to pump the fluid away from the damaged area. Okay, conservative treatments. Now, if it's necessary to receive treatment, things like deep tissue laser therapy are an excellent choice. This is me doing a laser treatment on, actually he's with the Korean Baseball League right now, Mike Wright. He got his first win yesterday. I saw that posted on his fan page on Facebook. Doing a laser treatment, it utilizes infrared light that helps to open up the microcapillaries to bring new oxygenated blood and help encourage that fluid to flow through there. Okay. So also things like dry needling, if you have muscle spasms, muscle trigger points, really tight tissues, dry needling is a great modality, and it utilizes an acupuncture needle. Now in the state of Florida, I don't do it. I have my acupuncturist that works with us. He is the one that does the dry needling procedure, but it uses an acupuncture needle. So it's really, really like a cat whisker is the way he describes it. It's a real fine needle. If you've ever had acupuncture, you know what that's like. It's not painful at all, but it helps to relieve the spasms and the trigger points in the muscles. Rock tape, kinesiology tape. If you're an athlete, chances are you've seen kinesiology tape on a shoulder. A lot of runners will use rock tape, or at least kinesio tape. Rock tape is just a brand of kinesio tape. I prefer rock tape just because of the adhesive quality of it, and it's a little bit thicker than some of the other tapes out there. But it helps to encourage normal movement and normal joint mechanics without restricting the mobility of those joints. As we talked about, mobility is an important thing, and we want to make sure that we're stimulating that stability of the joint while it's healing. And then prolotherapy is another thing my acupuncturist does in my office. I think everybody's heard of PRP and stem cell therapy. Well, those are two different versions of prolotherapy. In our practice, we do prolotherapy using a dextrose solution. And just like with the deep tissue laser therapy, it actually helps to stimulate the body's immune system and immune response to create a controlled inflammatory reaction around damaged tissues to help the body lay down new collagen and to heal up those tissues. Okay, pretty cool. Again, these are all topics, could be topics of other webinars completely. So I'm just skimming over the top of them, but certainly you can ask me questions. And let's go ahead and do that right now. Let's see if there's some questions that people have posted. No, not yet. Let's see, Q&A. All right. I hope everybody's awake out there. If you have any questions, go ahead and make sure you chime in. I guess the next question is that if what do we do now? What's the next step? And let's talk about that real quick. It's the last slide of the presentation. Oh, here we go. Got a question. I'm going to go ahead and so the question from Andrew, with shin splints, is it common to just get it in one leg? I've had patients that have had it in both, but I would agree that having it just in one leg is relatively common. I don't know the statistics of that. I never tracked it. You know, that issue, if it's just in one leg or both, but it is common to get it in one leg. I'd maybe 50-50. One leg versus another leg, which brings us to question well, let's look at it this way. If it is in both legs, you can surmise based on that presentation that the shin splints are coming from a growth spurt. Remember I talked about the tibia and the long bone growing faster at a faster rate than the soft tissues can manage. And however, if it's in just one leg, then you're looking at more of a foot mechanics, or maybe you know, one side of the glutes aren't firing correctly. Now, one thing that you'll find out if you know, we ever work together is that where you have the pain is almost never where the underlying issue is. Let me say that again. Where you have the pain, so if it's shin splints, for example, it's almost never where the original issue is, okay? So it very well could be coming from the hips, maybe poor hip mechanics. Maybe poor foot mechanics. Maybe the glutes aren't firing on that side. Maybe there's some pelvic instability. Maybe there's a knee issue. Maybe there's an arch issue in that foot that's causing an imbalanced stress force through the tissue. So keep that in mind, and it's real common. Clinicians make this mistake all the time too, is they'll treat an area where they see pain or where the patient or client is having pain, but they won't look along the kinetic chain. And real briefly, the kinetic chain, bear with me if you know what that is, but if you don't, the kinetic chain is that, remember I suggested that you balance on one foot. The kinetic chain literally is the intrinsic muscles of the toes, into the ankle, into the lower leg, into the knee, hip, and into the core. That's the kinetic chain for being able to balance on one leg. So for example, if somebody has, and I treat a lot of, because I'm involved in baseball, I treat a lot of elbow injuries. And oftentimes if somebody has an elbow injury, I always go to the shoulder to see what dysfunction is happening in the shoulder and work on correcting that as well as eliminating the discomfort and pain, okay? Let's see. Let's shrink that down. I think I had another question. Oh yeah, here it is. Okay. So no ice at all then. We deal with a lot of knee injuries on the mountain. The answer is yes, no ice. The only use for ice is for pain relief. Okay. So, you know, if you're dealing with injuries on the mountain, You have to ascertain and see if the injury is unstable. And that's, you know, you got to have somebody, maybe an athletic trainer or somebody that can evaluate for that. But you need to be conscious of using ice is going to create just pain relief. It's not going to prevent the swelling from happening, because as soon as you take the ice away, the circulation is going to kick back up again and you're going to get the swelling. You need to manage the swelling with movement and muscle contraction. I hope that answered that question. All right. Let's see, we answered that. Okay. Let me type this out. Did you hear that? Hopefully you heard that last description. I'm getting used to Zoom webinars, and I'll answer that again. No ice at all. Ice is only good for pain relief. And we can further that discussion at another time too, if I didn't answer that appropriately. All right, so let's go back into the presentation, just the final slide. And certainly if you have more questions, what I want you to be able to do is be able to contact me directly. I'm going to, this is, okay, you see this is my website for my clinic in Sarasota. In the follow-up email that you all are going to receive, you're going to have links to these pages. So in this, this link has free resources. Okay, so we have a download that you can all download these in real time, right to your computer. These are all foam rolling techniques and self-myofascial release for the hamstrings. Okay, the IT band, quadriceps, piriformis. Okay, tibialis anterior. There's one for shin splints. Okay, and don't tell me it hurts, because I know it hurts when you do foam roll your shins. Pelvic and glute stabilization. Okay, you have 4 different downloads that you can do, helping to fire this posterior chain here using a resistance band, doing that single leg RDL, doing hip bridging, okay, bridges on a stability ball, and then there's some other ones that you can look up. And then, please hold, there we go. Okay, so those are the resources that I have. Now, another thing that you can do is you can book a telehealth consultation with me. If you want to get on, have an in-depth conversation about a particular issue, even if it's for somebody else, that's fine. We can go ahead and book a 30-minute consultation via telehealth. That's going to be very advantageous. The nice thing is with the telehealth conference, just because you're not in the local area and I can't see you face-to-face, the telehealth consultation gives me an ability to kind of get an idea based on your history and how an injury presents itself, and to be able to take and give you some guidance. And that guidance could be, well, let's go ahead and get an MRI and we can help facilitate a diagnostic study, even if it's just an X-ray. I can help guide you in some of those exercises and what to avoid, what to implement, and be able to answer some of those questions. So that's the beauty of the telehealth conference. And then if you happen to be in Sarasota, you can go ahead and just book an appointment with me face-to-face. I'm available Mondays, Wednesdays, and Fridays in my office in Sarasota, and we can go ahead and cover everything for you in an in-office visit and do those same things. So I'm going to come back and see if there are any other questions. I don't think so. I want to thank you all for participating. If you have any questions that you think of after you jump off the webinar, or if you're actually watching a recorded version of the webinar, you can certainly email me at drken@Sarasota Sports, or sorry about that, that was my other email address. drken@sportsmedondemand.com. I'm going to be sending out a follow-up email that'll have those links in there. And you can also jump over to our Facebook page, SportsMed on Demand. Look that up, and you can share your thoughts and questions and what you thought about the webinar. And I hope it provided you some value and some tools and information that you can take home and utilize yourself. And also for the coach that wanted to, hold on, another chat. Yeah, thank you, Andrew. I appreciate it. Thank you, John, for your in Connecticut with our coach, and I want to appreciate all of you for watching, and I look forward to possibly seeing one of you if you happen to be in the Sarasota area. And otherwise, have a great day. Enjoy and get out and get some running in. Get some time outside. I don't know what it's like in other areas right now, but it is beautiful in Florida. I don't want to rub it in, but it's beautiful. So thank you again. Have a great day. God bless. Cheers.